you. And it's wonderful to be part of this great activity. I think we should have this more often so we get to see each other. I saw Kim after a long time. I was supposed to see him in next couple, few days, but unfortunately, due to a commitment in meeting, we'll be able to see him there. Anyway, so can you hear me okay, Nicola?
Yes, all good.
Okay,
Please
good.
carry on.
Yeah. This is regarding the consensus that WFNS Spine Committee did some time ago, and it's about to be published. It hasn't been published yet. It's wide variety of neoplasms that can involve the vertebral column, but METS is considered the most common pathology, with up to 90% of all spine tumors as metastasis. A primary spine tumor that we're going to discuss is much less common, and about 5% of all spinous tumors. These are heterogeneous group of neoplasms with diagnostic and treatment challenges. Prompt diagnosis and treatment is crucial, and a multidisciplinary approach is generally required. The treatment options will depend on type, location, and stage of the tumor, and they affect both the adult and the pediatric population. How do we do these consensus? We review published data of last 10 years. The authors collects and writes the data with the spine surgeons present in a meeting worldwide. We discuss and vote it twice with the help of these experts, along with the Delphi method. The authors do not present anything new from their side for everything that is out there in the data they present. Objective is to get their recommendation guidelines to neurosurgical trainees across the globe. So it's been our pleasure, and we have had brilliant support from some of our colleagues. And this is a WFNS Spine website. So it is wfns.spine.org. And if we go into recommendations or guidelines or into a homepage, etc., you can get a lot of literature. But you have all these publications on these topics already there, maybe starting from 5 to 10 papers on each of these. So all these are open access that are available here. Starting with cervical spondylomyopathy, with the spine trauma, spinal cord injury, osteoporotic fractures, spine thoracic fractures, and low back pain and lumbar disc prolapse. So you can access it for free anytime you want, and it's wonderful papers done by the top people in the world. We usually do a literature search, and this is the kind of template that we have for it. So let's come to the primary bone tumors. So, various people, 5 different people did these talks. And of those talks, I'm just getting a brief summary out of it. So primary bone tumors are benign and malignant. So obviously, osteoblastoma most common. Hemangioma most common, and osteoblastoma, giant cell, osteochondroma being present. In malignant, plasmacytoma is the most common in these malignant tumors. So first of all, incidence and epidemiology. We did a literature review for last 10 years. Benign locally aggressive tumors are chordoma and giant cell. They're a small subset of primary vertebral tumors which are histologically benign but locally aggressive. These tumors make up a unique and distinct group that many experts consider both benign and malignant. Chordoma represent 2 to 4% of all spinal columns and tumors, and have a high propensity for the sacral and cervical regions. Although these tumors frequently do not metastasize, they recur locally in an aggressive fashion. Giant cell tumors demonstrate grade 1 histologically, but may recur locally. More ominously, these tumors have the potential to metastasize to lung, therefore considered malignant. Anatomical distribution, we know chordomas have a particular preponderance in sacrum and coccyx, followed by skull base and mobile spine. Giant cell tumor tend to occur in sacrum and thoracolumbar spine. Plasmacytoma and chondrosarcoma are in thoracic spine. ABC and osteoid osteoma, osteoblastoma are common in lumbar spine. Chondromas are predilection for cervical spine, especially C2. So the statements regarding epidemiology that we have are primary tumors of spinal column are rare. The most common malignant primary spine neoplasm in adults is chordoma, followed by chondrosarcoma and osteosarcoma. In children, most common primary malignant vertebral tumor is Ewing's. The most common benign is osteoblastoma and osteoblastoma, ABC, and eosinophilic granuloma. Chordoma accounts for 2 to 4% of all spinal column tumors and 40% of primary spine tumors, and has a propensity for sacral and cervical region. Giant cell is grade 1 histologically. They are the second most common primary tumors of sacrum after chordoma. The incidence of primary malignant vertebral tumors increased significantly in patients older than 40. Biopsy is able to differentiate tumors and accurately determine the type, grade, and stage of these tumors. Radiologically, if we it's widely available, is fast, inexpensive, slow alignment, shows alignment of the tumor vertebra, defect in fractures, deformities, reveal calcification, ossification, cannot show soft tissue of the spine nor intermedullary or extramedullary tumors, limited sensitivity for detecting early stage or small tumors, and exposes the patient to radiation. CT, widely available, relatively inexpensive, provide detailed cross-sectional imaging of spine and tumor, sensitive to bone structures, detect bone destruction, fracture, calcification, scan the entire spine in few seconds, and limited sensitivity and specificity for spinal cord, nerve root, or meninges. Again, radiation is a problem. MRI, highest resolution and contrast allows for clear imaging of the soft tissue. It identifies tumors based on signal intensity, enhancement pattern, and diffusion characteristics. It's sensitive to nerves, better evaluates the invasion of spinal cord, root, or surrounding soft tissue. There is no radiation, safe for children, longer examination time, larger noise, limited sensitivity and specificity for bone structures, not suitable for patients with metal implants or devices. Bone scan, inexpensive, but low specificity and poor resolution, may miss tumors with no abnormal bone metabolism. PET, higher spectrum and spatial resolution, provide clear imaging of tumors and surrounding soft tissue, provide biological behavior and aggressive information, highest costs, lower availability, and if affected by inflammation or infection. Pathology and radiological characteristics. So osteoblastoma, typical, surrounded by these high signal bands reflecting bone formation and high signal puncture sclerosis in the translucent area. Hypointense on T1 and hyperintense on T2, as you can see here, and cortically based red, gritty, or granular lesions. Osteoblastoma are punctate, linear or patchy, high-density lesions, signals in the lesion, and reactive sclerosis around the lesion, as you can see here. A giant cell tumor is typical, osteolytic and eccentric, and typical soap bubble appearance, as you can see here. It's multinucleated giant cells in it. Hemangioma, soft, well-demarcated, and dark red mass, excuse me. Multiple small vessels with sclerotic trabecular bone, and reactive new bone formation in these. What about the primary malignant tumors? So chordoma, microscopically is completely different, and again you can de-differentiate and poorly differentiated and conventional chordoma. So there are 3 types depending on and the outcome is different, obviously. It's lobulated and heterogeneous lesion, as you can see here, shows iso-intense to hypointense on T1 weighted image, and hyperintense signal on T2 weighted image with a relevant enhancement to the contrast enhancement. Chondrosarcoma, extensive bone destruction with cloudy or speckled calcification, as you can see here. Small hyperintense focus on the MRI heterogeneous enhancement contrast injection. Osteosarcoma, bone destruction, indistinct margins, cloudy osteoid calcification within the tumor, and periosteal reaction at the tumor edge. Statements for WFNA Spine Committee: MRI and CT are crucial to visualize neural compression, tumor load, and the bony structures. Management of primary vertebral tumors, surgical management, epidemiology, and survival. Retrospective study, and they looked at it, and surgical resection was the primary mode of treatment for chondrosarcoma, chordoma, and osteosarcoma. The treatment of Ewing sarcoma was multimodal. 5-year survival rate varied significantly with chordomas and chondrosarcoma having the greatest survival. Surgical management of primary bone tumors of the spine. So, this is a validation of approach to enhance cure and reduce local recurrence from 2011. And the final verdict of the margin was by pathologists reported patients analyzed either anything appropriate or anything inappropriate in the surgical margin, not recommended by anything classification. And obviously, once they had that, the outcome was different in these patients. Surgical management of primary bone tumors of the spine. Again, significant reduction in first local recurrence when primary bone tumors are resected with anything appropriate. Local recurrence has the highest concordance with mortality. So I think that was showing that our anything should be followed generally. The Anneking and WBB classification system are the most widely accepted system for classifying benign and malignant primary spinal tumors and provide recommendation on the best treatment options, including surgical approach. First-line treatment for osteomas is NSAIDs. For patients with failed conservative treatment, surgical resection may be considered. Minimally invasive procedures, including radiofrequency ablation, has similar outcome and sometimes better to surgical excision of these osteomas. But caution is warranted when the lesions are close to neural structures. For osteoblastomas, in-block resection or maximum safe gross total resection lower the risk of tumor recurrence is recommended. Further studies are required. Preoperative embolization for ABC is essential. And, you could have, there are studies out there with various things with standalone selective arterial embolization, bone marrow aspirate injection, denosumab, doxycycline, bisphosphonates in the primary treatment for ABC. For giant cell tumor, preoperative embolization for hypervascular lesions followed by in-block or gross total resection is recommended to minimize tumor recurrence. Symptomatic hemangiomas should be treated with preoperative embolization given the high vascularity, followed by gross total resection. Radiation therapy, so the landmark papers, obviously we know have been out there, many of them. So primary malignant tumors can be treated either surgically or non-surgically. In the non-surgical context, radiotherapy of malignant tumors have been considered the gold standard, but the goal of radiotherapy is to destroy the tumor cell while simultaneously avoiding damage to the normal structures. Radiosurgery, how much does it help? So there are keynotes. The technological advancements have transferred the standard of radiation therapy for spine tumors. Precise targeting and minimal collateral damage are the key goal. Definite local treatment of unresectable tumors has been a part of radiosurgery now. Radiation and Ewing's surgery is more effective than radiotherapy with achievable adequate surgical margins. In cases with inadequate surgical margins, adjuvant radiation dose radiotherapy is not effective. Radiation therapy for chondrosarcoma, is it really there? So external radiation, source therapy, modified fraction radiotherapy, internal radiation therapy, and particle therapy are all already out there for inoperable tumors. Survival rates depend on dose, age, tumor size, quality of surgical treatment. Adjuvant radiotherapy, study on adjuvant radiotherapy for spine sarcomas, high local control in patients with primary tumors observed, acceptable late morbidity. What about charged particle therapy? Charged particle therapies for sarcomas of spine and sacrum, 5-year therapy outcome as shown here with proton beam. If different outcomes are shown here, is obviously better. Carbon-9 is less than that, and followed by combined photon beam therapy has better results. So in conclusion, evidence for charged fit therapies in spine and sacrum sarcoma is limited. Preliminary evidence suggests comparable local control and outcome at 5-year among charged particle options. Radiation therapy for primary vertebral tumor is may be becoming a gold standard in near future. Statements: stereotactic radiosurgery serves as a promising post-operative adjuvant or salvage treatment for achieving good local control in primary malignant spinal tumors, especially CBRT, and suggested approved patient's outcome. Conventional photon radiotherapy is supplemented by more advanced techniques, including modified fraction radiotherapy, internal radiation therapy, and particle therapy. Combined IMPT and IMRT have promising long-term results in spine tumor patients. Charged particle therapies for sarcomas affecting the spine and sacrum are limited by current evidence. So it was really my pleasure.